Our next speaker after that wonderful talk, I thought, is Dr. Christopher Richards, with whom I have the pleasure to share an office. It's always nice to have somebody who really knows what he's talking about. Dr. Richards will talk to us about bronchiectasis, the pathophysiology and emerging therapies, and it's all yours, Chris.
Okay. Thank you, David. It's also a pleasure to share an office with you, and also to have gotten to hear Dr. Neringer's talk, who's been a great mentor to me over the years. So I'm Chris Richards. I work in the bronchiectasis program here at Mass General, as well as the CF program that Dr. Neringer spoke of, and I'm involved in our newly launched pulmonary genetics clinic. So I'm going to be talking today, though, about bronchiectasis, what the current state of pathophys is, and some new emerging therapies that are just on the horizon. These are my disclosures. None of them some are relevant to this talk, actually, in terms of some educational advisory boards I do for Insmed Pharmaceuticals. So we're going to talk about the prevalence epidemiology of bronchiectasis, where our current understanding or thoughts about the pathophysiology lay, talk about different etiologies, how we go about making an early and accurate diagnosis. We'll talk about how the disease is treated, both from the point of view of guidelines and also sort of expert practice. And we'll talk about how to identify what a bronchiectasis exacerbation is and why the identifying and treating those early is so consequential. And then towards the end, we'll talk about these new therapies that are coming out and clinical trials that are currently underway. So, bronchiectasis really is not one condition. It's the final common pathway of multiple disease states, whether that be the well-recognized and characterized condition like cystic fibrosis, whether that's other genetic conditions like primary ciliary dyskinesias, or it's the result of recurrent lung injury from recurrent infections, or maybe a isolated injury to part of the lung from an obstructing mass or prior radiation exposure. All of these different insults to the lung can wind up leading to these dilated heavily mucus producing airways that are prone to both acute and chronic infections and subsequent remodeling. So since one of the hardest things about bronchiectasis treatment is to try to figure out when to consider the diagnosis. When you look at some of the presenting symptoms, it's things like chronic cough, dyspnea, recurrent bronchitis that may happen 1 or 2 times a year, but none of that is necessarily specific for the diagnosis of bronchiectasis. Sometimes we'll stumble upon a conversation with a patient whose symptoms are significant enough that your mind goes straight to further workup, whether this is the person who has almost like a bronchorrhea, a heavy productive cough every single day, person who's having recurrent low volume or has had episodes of higher volume hemoptysis, someone who is constantly on antibiotics for recurrent infections. Those are people clearly the thought about advanced imaging comes to mind pretty early. Then you also have to think about some of these other conditions where there is a significant overlap between bronchiectasis and COPD or asthma. These are not exclusive conditions. They can overlap at the same time, but the difficulty is when you've made a diagnosis of asthma or COPD, and that represents some, but not all, the features that the patient is telling you about, coming back, reconsidering the imaging and saying, actually, there might be more of an airways issue in the terms of bronchiectasis than I initially thought. And then the other part of this is, sometimes we will meet people who have autoimmune conditions, immune deficiencies, and they're coming in with recurrent chest infections, but they have yet to ever had cross-sectional imaging of the chest. And so those are patients too, whom right background, get a CAT scan and start to move forward with the diagnosis. And the reason that one of the things is about bronchiectasis is that it's clearly been the knowledge of bronchiectasis and the diagnosis of bronchiectasis has been increasing over time. There also seems to be just a general trend in the population for more risk factors and more new cases. And we do know that from this, that the epidemiology really sort of swings heavily towards women in their 60s to greater than 70s. We're going to represent the majority of cases. There's a significant number of men who also have the condition at those ages, but it is disproportionately an illness that affects women. One of the other things to kind of realize is that we probably are seeing cases of bronchiectasis in the clinic and looking right past it. And the reason I say that is because if you look at studies of low-dose CT screening for lung cancers, this one was done down in New York. There's also been a European cohort. Find that almost 25%, a quarter of those cases have bronchiectasis, like legitimate radiographic bronchiectasis on the scans. Now, whether that correlates or with symptomatic disease, that's not as straightforward, but there are a great number of cases of bronchiectasis that we may just be overlooking. The reason we are knowing more and more about the incidence, the prevalence, who has the bronchiectasis is because of an initiative called the Bronchiectasis and NTM Research Registry. This was started a number of years ago, for about 15 years ago. It's about 25 to 30 sites now, and we've included about just approaching 7,000 registrants in this database that we can use now for clinical trial recruitment, answer questions about epidemiology and causality. And so this is a very powerful research tool that's been developed. And what we know from that registry, US-based registry, is that if we look past just bronchiectasis, we look to mycobacterial disease as well. 60% of the patients in this registry have NTM infection. Not surprising, it's an NTM registry, but it does again highlight the burden of these chronic infections in bronchiectasis. And this registry also, restates the fact that most cases of this illness are seen in women. And what we also know is that the people who do not have NTM infection in the registry tend to have other comorbidities like asthma, immune deficiency, or primary ciliary dyskinesia. They tend to be more apt to be colonized with Pseudomonas, and for whatever reason seem to be exacerbating more frequently than the group who have NTM. So there's definitely differences in the populations of patients with bronchiectasis, and this is not meant to be anything more than an example of how, with a registry, we're able to tease out smaller differences that we may not have been able to previously been able to have had a grasp on. One of the things that the registry has also taught us is that the distribution of the airway findings is uniform throughout the lung. And this is something I'm bringing up because I was taught in my fellowship, my residency all along, that cystic fibrosis is the disease of upper lobe bronchiectasis. And if you see upper lobe bronchiectasis, you should immediately think cystic fibrosis. But the fact is that's just not true. I mean, when we look at the registry data, I don't think there is the majority of patients in these cases who don't have CF also have upper lobe disease. So I think sort of comments like that or teaching points we carry with us may not actually match up with what we do know about the disease. And now for the pathophysiology, this is where the current state of thinking is. It's this idea of the vicious vortex. And the idea is that you have these nodes of illness that occur in the lung, some sort of epithelial dysfunction. You have a overexpression of over-inflammatory response. You have these chronic bacterial or fungal infections. And then you have this abnormal healing process that leads to the bronchiectasis. And the old thinking was, well, this is just a cycle. One leads to another, leads to another. But really, they all interact with one another. And there is a pathway between every node on this chart and one another. And so all of a sudden, it might seem more complicated than a simple cycle. But each one of these pathways is actually an area you can exploit to get a better outcome and get better treatment. Just to move, so that's where our physiology lays. This is an example of a pretty obvious lower lobe bronchiectasis, where you can see with the green arrow, these very dilated cystic airways. The blue arrow here is highlighting a hyperattenuating filling defect of that airway, which is actually in this person's case underlying ABPA, and that is a very large kind of crystalline mucus structure that's in that airway, but a good example of what bronchiectasis looks like. Cross-sectionally, again, you can see on this patient in the lower lobes, upper parts of the lower lobes and the middle lobes of the lung, very wide, very dilated, thick-walled airways, even airways that have sort of an air-mucus interface. This is our examples of rather obvious and severe bronchiectasis. Under a microscope, what you're seeing is on the right side here, this is what a normal epithelium looks like. You have a very, uniform ciliated epithelium. You've got a host of different cell types, goblet cells, and then the like here. You have a very thin basement membrane, and then you can see vascular structures. You can see the interstitium of the lung and airways as well. But then what you have here in the bronchiectatic airway, you've got a loss of that ciliary definition, a thickened basement membrane. There are pro-inflammatory cells in that epithelial layer, and then all of this sort of multinucleated cellular infiltration throughout the lung tissue as well. If we think back a little bit more about what causes bronchiectasis, well, most cases, 40 to 30%, we do not have an explanation for, so-called idiopathic. Post-infectious cases are relatively common, about a quarter. And then where there's an interesting difference is this diagnosis of COPD. So patients who were former smokers who have emphysema on their CAT scan, as well as bronchiectasis, mucus plugging, bronchial wall enhancement, not just features of a chronic bronchitis. That is a condition that is really swings heavily towards men over women, and then you can see a handful of other diagnoses, but the prevalence really drops off pretty rapidly once you get beyond those first three etiologies. So how do we go about the diagnosis? Well, I showed you that imaging. That imaging is the method of diagnosis. This is a radiographic diagnosis. There's clinical features to it for certain. Some people have those features of chronic productive cough. Not all do, though. And so this is radiographic. Always worth going back and looking at prior imaging of the abdomen, the head and neck. Maybe you capture just a small slice, a coronary CT, small slice of the lung. You can see evidence of this process well in the past. You can start to get a timeline about when this started and how it's been evolving. But once you get that, that high resolution dedicated CT scan of the chest, that's when you're going to start to do things like function testing, always get a CBC with differential, looking for eosinophils. I believe strongly that respiratory cultures need to be collected regularly. This is because sputum cultures are not 100% sensitive. So if you just get one at the outset of diagnosis and it's negative, doesn't mean that there's not a chronic colonizing bacteria. I mean, it may just mean we weren't able to grow it. The microbiology changes over time, and it's also helpful to know if someone gets sick, what bug are you going to be treating? And so getting these cultures at regular intervals in health and at times of illness is something I do in my practice and is quite helpful. I always make sure that we do some basic immunologic workup, looking at IgG levels and various subclasses, and always get an IgE. If there's concern for aspergillus, that's an ABPA, that's a workup on its own. Cystic fibrosis workup, what Dr. Nuringer just spoke of, is certainly helpful in bronchiectasis. It's yet to be clearly defined who and when and with what, but that is something that we are working on very intensely, trying to provide guidance to everyone on how to bring that into your workup. And then, of course, I always look into things like autoimmune illnesses and also testing when it makes sense for specific illnesses. One other thing to note is that where you work in the world, there's going to be a different pattern of etiologies of bronchiectasis. So just because in the United States we have more immune-related conditions and post-infectious causes, doesn't mean that, in places like Western Europe, there's not a higher incidence of idiopathic causes. So it's just every place in the world is a little bit different, and knowing where you work, knowing what the causes are, can certainly help tailor your workup and your treatment. Talked a little bit about this neutrophilic. We'll talk more about neutrophilic inflammation in the lung and how that relates to the pathophysiology in future treatments. But it's also worth noting that while the primary inflammatory cell type in the lung that is dysregulated in bronchiectasis is the neutrophil, still about 20% of cases will have some sort of eosinophilia, either peripheral on BAL or even on biopsy. And those 20% of patients, 20% of cases tend to be the ones who have quicker recovery from exacerbations, have more of an asthmatic or spastic airway phenotype, and also are responsive to IL-5 biologics, if you can link the patient to that type of inflammation. The way that the neutrophil inflammation works, though, is that as chronic inflammation, bacterial colonization, mucostasis develops in the airways, neutrophils are attracted in to degrade and clear out those processes. They degranulate and release things like neutrophil elastase and other MMPs into this milieu. But as the neutrophils die, as the degranulated enzymes fail to destroy the bacteria they intend to, as DNA builds up from all the deceased neutrophils and bacteria, you get this very, very sticky mess with all of these different enzymes built into it. And it's sort of we call it a neutrophil extracellular trap, but another way to think about it is sort of a minefield of these enzymes that are ready to act at any moment, leading to a chronic low-grade inflammation. The type, the amount of inflammation in the lung really does vary on the person and what symptoms they have. So, for instance, these are each table here, or each graph here represents a different measurement of inflammation in the lung. And, the first one here, this is people with chronic Pseudomonas tend to be much more inflamed than, let's say, someone who has, quote, dry bronchiectasis, doesn't cough anything up. And then for those patients who have high sputum production every day, they tend not to be as inflamed as the chronically infected patients, indicating that maybe going about their management of their major symptom, a chronic productive cough, with anti-inflammatory therapies may actually miss the point for them. But these are sort of just the idea here is that inflammation is mostly neutrophilic, but there are subtleties and subsets of patients within that may guide who does and does not respond to different types of therapies moving forward. There are some genetic underpinnings to bronchiectasis. The most obvious one is mutations in CFTR, and it's pretty clear at this point there's a spectrum of illness in CFTR dysfunction, all the way from the patients who are homozygotes of a 508 mutation in CF to people who are carriers of a relatively benign CFTR mutation, but all have some degree of chronic lung disease, like Dr. Nuringer was discussing. So if you have suspicions for wanting to rule out cystic fibrosis, it's pretty easy these days to use pretty easy and fairly inexpensive to the patient to do some full sequencing of the CFTR gene. Sometimes that always needs to be coupled, though, with a sweat test to know if the finding you're having is physiologically meaningful or not. But there's definitely a role for that we still need to define. Primary serial dyskinesia, that is a topic in itself. The genetics of that are very complicated. And if you, for whatever reason, wind up doing a PCD panel, have positive findings, it still remains very, very complicated, and referral to a large center with history with PCD, or provider with history of PCD treatment is going to be really helpful, because not all mutations there carry important consequences. Now, one of the things that we talked about, I mentioned earlier, was this I believe they really do need frequent sputum cultures on patients with bronchiectasis. And, the reason is that from these different sources, whether it be the Embrace trial, which was using macrolides to reduce symptoms, the BAT trial, which was macrolides to reduce exacerbations. There's also the BLESS trial, and then there's the bronchiectasis registry. I mean, you can see that there's a wide variety of different, there's a variety of different distributions, but these are always the same several bugs: Pseudomonas, H-flu, Staph, Moraxella, NTM, and then normal flora. So these are the ones that come up. And, if I'm seeing a patient who's I have no suspicion for bronchiectasis, but they've got this chronic bronchitis, they've been on antibiotics several times, primary care is sending them to me, and I'll get a sputum culture. And if I grow something like Pseudomonas, or I grew something like Stenotrophomonas, something that I'm not expecting, that's when I might start going down the pathway of looking into their airways more than I would have otherwise, because there's no reason, someone with a chronic bronchitis, otherwise healthy, should be growing Pseudomonas in their sputum. But there is a lot of evidence that someone who's growing Pseudomonas in their sputum would have bronchiectasis. So exacerbations, this is really where the bulk of the real work comes from. The diagnostics, that happens in the background, that happens at the first meeting, but the exacerbations are what you wind up having to help patients with moving forward. So one tricky thing is to try to help a patient and yourself understand what an exacerbation is. So, in clinical trials, it's defined as the change in 3 or more symptoms for over 48 hours that include cough, sputum volume, color, breathlessness, fatigue, hemoptysis, that lead to a treating physician agreeing that a change in therapy needs to be made. Okay. The more realistic one is a change in respiratory symptoms that's enough for a patient to give me a call and say, I don't feel right. And so I invite the patients to call me, anytime that's up in the air, because I don't want them waiting and waiting and waiting 3, 6 months, whatever it is, for a follow-up to finally bring up that they've been feeling off. Symptoms exacerbations include, most frequent one is cough, breathlessness is up there, change in sputum color, fatigue, the amount of sputum may change. Fever happens. It's not one of the major findings. And the other thing is that, this is bronchiectasis. This is usually an inter-airway problem. And if you meet a patient who is going to urgent care, going to primary care, emergency care, something like this, with cough, but no fever and a normal chest x-ray, they'll be told that, oh, it's a bronchitis, forget about it. But that's not really the case. This is different than bronchitis. This is bronchiectasis. So this is just sort of a description of all the different kinds of symptoms people have. And the reason it's so important to get patients into the habit of calling you is that symptoms, right, can begin 10 to 14 days before a patient ever calls you. And the longer they wait to call you, the longer the period of illness continues. So if you could start to intervene on cases 3, 4, 5 days in, rather than 10, 12, 13 days in, you're going to have better outcomes for your patients. More exacerbations tend to lead to more exacerbations. That's why it's important to get on top of patients earlier. Patients who have atherosclerotic disease and exacerbations, they have higher rates of mortality. People who have asthma and bronchiectasis are more apt to wind up in emergency departments with harder to manage asthma exacerbations. And for those patients who exacerbate 3 or more times a year, those are the ones whose actually their survival drops. They're hospitalized more frequently, and their survival drops. I mean, the 5-year survival of someone with no exacerbations is about 95%. But once you start to have 3 or more, you're going down to the 80% range, which is a significant issue. And so our goals of treatment really are to decrease cough, improve symptoms, improve lung function. And so how do we go about doing this? Well, there's the baseline airway clearance I'll talk about in a moment, but generally speaking, when someone is exacerbating, the goal is the common practice is about 14 days of antibiotics. That can be tailored depending on how significant the symptoms are, but often if you treat for 5 days, symptoms wind up recurring just a little bit later on. So practice is usually about 14 days of oral or, if necessary, IV antibiotics. And it doesn't really matter the trigger. Most of the triggers are viral, but if you left a viral infection when someone who's chronically infected with Pseudomonas then the Pseudomonas is still a problem. You're not treating that, even if you are right that treating the viral infection is not necessary. And what we do know is, going back to that prior slide with information about the inflammation in people's airways with different phenotypes, people who get antibiotics to treat exacerbations across the board have lower measures of inflammation in terms of neutrophil elastase, TNF alpha, interleukin 1 beta, these other types of measurements. So there's evidence that if you treat early, you use antibiotics, you drop the inflammation in the lung, then presumably that would lead to better outcomes, less lung remodeling further down the road. Now, as far as other ways to treat bronchiectasis, well, there's a couple of different societies that recommend things. The European Respiratory Society, British Thoracic Society, the IDSA, all have management guidelines for bronchiectasis. But what we do, truthfully, is treat it any which way we can. If that means bronchodilators, inhaled antibiotics, anti-inflammatory drugs, surgery, pulmonary rehab, and airway clearance, all of these things have a role to treat. And airway clearance really is the fundamental, that's the baseline. It has to be sold to the patient as the fundamental way to do this. There's a bunch of different examples of how you do that here, but people who do airway clearance, regardless as to whether they make mucus or not, do better in the long run. They have fewer exacerbations, they have fewer burdens, symptom burdens. We don't know what type or what frequency or how long is optimal, but I think creating in someone's mind that this is a long-term habit, sort of like flossing, that need to be doing every single day, that's the goal. And I always combine airway clearance with a referral to physical therapy here, or referral to nursing to review all the devices, the nebulizers. So it really does get hammered home that this is essential. If I give someone an a cappella device, nothing's going to happen. But if they have all those other pieces in place, they're going to be much more likely to maintain that sort of treatment. Pulmonary rehab and exercise have been shown to be very helpful. And then there's these sort of things that we can do to nebulize therapies, right? So right now we use mostly mucoactive agents. We use things like hypertonic saline. That tends to be something in the 3 to 7% range is what's helpful, usually once or twice a day. N-acetylcysteine has a role. It's not as well tolerated, not as helpful in studies as the saline is, but some people do benefit from it quite a bit. Dornase is not approved for NCFB, but it is approved for cystic fibrosis. As far as traditional inhalers, having bronchodilators makes sense, but we try to avoid inhaled steroids because they don't add to anything in the studies, and also presumably will be slightly increasing the risk of a bacterial exacerbation, just given the nature of that drug. Inhaled antibiotics are very helpful. The most commonly used one is topramycin. It is best paired with someone who has a chronic pseudomonal infection, but it doesn't have to be. You can still use topramycin without that. And then, there's other antibiotics as Trianam, Colistin. Those are very hard to get insurance payer approval for, but the topramycin you usually can, if not at a high cost. And then there were trials in the past for inhaled ciprofloxacin that really did not wind up having much of a clinical impact. When we think about anti-inflammatory drugs, this is where a lot of the research and new therapies are coming in. So eosinophilic disease, there's a number of ways listed here as to how to identify them. Those are people I really do get very good benefit from using the IL-5 inhibiting drugs. And then if you're trying to distinguish it, you can also, you measure things like FeNO to distinguish eosinophilic from neutrophilic disease. One treatment that's very, very helpful is our long-term macrolides. So there's been 3 trials, Embrace, BAT, and BLESS, all looking at a different sort of vantage point on how long-term macrolides reduce exacerbations and reduce symptoms. And in every case, there's clearly a role for these. I think they're underutilized, but you do need to be aware of chronic hearing loss. You do need to be aware of the QT prolongation, and you absolutely, absolutely need to make sure that these patients do not grow mycobacterium before you start or at any time while you're using it, because unopposed use of macrolide on a patient who has MAC is going to lead to about 70% of those patients will become macrolide resistant within 30 days. And then that treatment becomes much more complicated. So that has to be measured and monitored very closely. There are examples, this is the imaging from before, where surgical treatment can be helpful, usually limited to one lobe of the lung, where maybe there's a place where there's recurrent hemoptysis. We do definitely use surgery to help, but this is in the setting of a prolonged lead-in with antibiotics and then a period of antibiotics afterwards as well. Now we're going to talk really, I wish I got into this sooner, but this was just actually a new phase 3 was published in the New England Journal just 2 days ago for this drug, Bronchiectasis. What it does is it inhibits this enzyme called DPP1 in the bone marrow from a myeloblast to a promyelocyte as it's progressing along to make a neutrophil. And that DPP1 is what has a lot to do with the cleavage and production of different enzymes that wind up in the granules of the neutrophil. So by decreasing that granular, those inflammatory cytokines, inflammatory enzymes in the granulocytes, you get less of these traps. That's the idea. In the phase 2 study, which was 2 different dosing arms, definitely an improvement in the patients with exacerbation on the drugs versus placebo. And then that led to this phase 3 study called Aspen, which unfortunately for this talk was just published days ago. But in Aspen, it was a phase 3. It was 2 different dosing arms and a placebo arm. And the primary endpoint was number of exacerbations. So these people had to be exacerbating 2 or more times a year. And were always had to be able to produce a sputum at their appointments. And then there was a series of secondary endpoints. And in that study, which is just published, what they showed was that there was about a 20% relative reduction in both time to first exacerbation, number of exacerbations, quality of life scores, between actually in both doses, 25 and 10 milligrams compared to placebo. And in the 25 milligram group, there was also an improvement in lung function over time. So this is the current state of the art, just published data. Probably going to hear a lot more about Bronchiectasis in the near future. Other things that are in the pipeline are trying to look at IL-33, anti-IL-33 antibodies, a repurposing of the drug infesterine to the combined PD3, PD4 inhibitor currently approved for COPD. There's a phase 2 for that, looking at use in bronchiectasis. There's this other drug from Boehringer Ingelheim, which phase 2, which is a caspase C inhibitor. Caspase C is the same thing as DPP1. And then, of course, the Bronchiectasis just concluded, published phase 3 trial data for this drug as a DPP-1 inhibitor. So those are the things in the pipeline in the near future. Other thing I do want to just plug is that in the last 3 months, we've also had the launch of the Bronchiectasis and NTM Care Center Network. It's a group of 33 centers across the United States, including Mass General, where patients can be referred to for management. The idea is we get more uniform management, earlier intervention and treatment, faster diagnoses, and then kind of being able to publish best practice guidelines for the United States that aren't currently available. This is something that is newly launched and hopefully hear more about. Here's a QR code for a bronchiectasis symptom tracker I designed for the COPD Foundation, where patients can try to get a sense of whether they're having an off day or a good day. And then here is another thing we developed for the COPD Foundation called a Bronchiectasis Action Plan you can give to your patients and kind of have them keep note of what they're doing for their management. These are symptoms to look out for. These are symptoms to call about, and just organize everyone's thoughts about chronic illness that can have subtle changes that slowly escalate over time. So that was my talk. Lot to cover. Hopefully next time I give it, there'll be even more to cover. But thank you for everyone for listening.